So we've reached the point in kind of going our way through chronic diseases that these are things that are outside of osteoarthritis are somewhat more rare. Okay, I don't know if you can be more rare. You're just rare. It's like you can't be very unique. It's just unique. We'll go through low bone mineral density, which mostly affects you ladies, osteoporosis. We'll talk about osteoarthritis, which is degeneration of joints. Okay, and this is the easily kind of one of the most common ones of the stuff. And then related in some ways to osteoarthritis is going to be low back pain. Some low back pain is due to osteoarthritis. Some may actually be due to osteoporosis. And then others may be due to kind of unknown causes, repetitive stress kinds of things. And we'll also talk about rheumatoid arthritis, which is relatively rare, but quite painful and terrible and awful. And our best treatments for are basically going to shred your immune system, so you're going to get some other kinds of kind of weird things that are going to go along with that. Okay. So, like so many things, I imagine you guys talked about this in anatomy. You guys talked about bones and bone structure, right? And you know, we're not going to get into all of the details that are going to be kind of a part of this. Why is this thing not working? Okay. All right, I guess my clicker isn't working. Bone has this kind of spongy core. It's called trabecular bone. Okay. Then it's got sort of what we are really going to think of, or what most people think of as is this kind of harder, much more mineral dense part of the bone. And then in there, there's also going to be a little bit of blood flow into these bones. Okay. And then at the ends of these, where they're going to meet and form joints, we're going to have what we call articular cartilage, right? And so most of the things that we go through today are going to affect either, right, the part of the bone where we have mineral deposits, okay, here, or it's going to affect this kind of articulating cartilage, the things that are happening on the end. Okay? So we're not going to get into too much of kind of the individual parts of the bones. All right. So to understand, we're going to start off by talking about osteoporosis. So to understand osteoporosis, we have to understand where bone comes from and what all is going on as it relates to sort of calcium metabolism within your bones and within your body. Okay? So you may not think about it this way, but bones are like your muscles. Okay? Bones are like almost any other tissue in your body in that they are always in somewhat of a state of flux. Okay? So there is a process by which you are going to break down some bone and resorb or reabsorb the calcium that's in those bones to use elsewhere. Or there is a process where I'm stressing and I'm loading the bones in a certain way. And because I'm doing that, I'm actually going to stimulate the formation of new bone, where we're going to put calcium into these bones. Okay? This process is driven in large part by two different kinds of cells. Cells called osteoclasts and osteoblasts. Okay? An osteoclast is a cell that eats bone. It breaks down the bone that you have. Okay? It's going to break it down. It's going to release that calcium out of the bone, and you can take that calcium up into other sorts of tissues. Okay? Conversely, osteoblasts are going to be cells that are going to form new bone. Right? They're going to form new bone. So there's this flux or this battle, if you will, this competition between osteoclasts and osteoblasts going on in a lot of the bones in your body right now. Okay? And so what we would like in a general sense is for the kind of balance between these two things to be roughly equal. Okay? That means your bones aren't getting any bigger or any more mineral density in them, but they also aren't losing that and getting smaller or more porous. Okay. So the regulation of these two things is rather complicated. Right? It's rather complicated. Well beyond the scope of what we're going to do in here. Dr. Mike will talk about it a little bit more in exercise fits, only because exercise, loading the bones, especially resistance training, is one of the big signals that will drive, osteoblast activity. Okay? There's a lot of stuff that we know. There's some hormonal influences in these things. There's an influence with vitamin D. There's an influence with parathyroid hormone. Okay, there's a whole bunch of things that are called circulating microRNAs. They're going to play a role in this, but we'll kind of just cover the very broad strokes with all of this. Okay, if you are a person, okay, who is becoming osteoporotic. Osteoporosis is a condition where over a long enough period of time, the osteoclast activity sucks out a lot of the calcium in your bones. Okay, so osteoclast activity predominates for a relatively long period of time. Okay? When that happens, then your bones become weaker and more brittle. And that means they are much more susceptible to fractures if you fall down. Okay. And they may also then change your posture, as you're going to see, like if you've got deterioration in your, in the vertebrae in your spinal cord, then as the bones are going to kind of lose some of their thing, and the structure is going to go away, and it may change your posture. Okay. The primary risk factor for developing osteoporosis is being a postmenopausal woman. Okay? Ladies, estrogen interacts with parathyroid hormone. Estrogen provides so parathyroid hormone, when it goes up, it drives the function of osteoclasts. Okay? Estrogen plays a big role in driving osteoblast activity, or at the very least, inhibiting osteoclast. Okay. So the primary thing that happens in postmenopausal women is estrogen levels plummet, and then that begins the process of allowing osteoclast activity to begin to increase. Okay. When you have osteoporosis, the places that we're really concerned about are going to be in vertebrae, and especially in sort of your femur and your hips. Okay. And so these are going to be the places that we look, and we're going to see how much density or how much calcium basically is in those bones. So here is the matrix of normal bone. Okay, you can see how it is much, much denser, much more tightly packed, and any of the pores don't look nearly as large as they do in an osteoporotic one. Okay, right. So this might be, this might be McKenna's hip now, and then this might be McKenna postmenopausal at 70 years of age. Okay? This can be what these things look like, right? The way that we diagnose osteoporosis is pretty simple, okay? The standard of care is to have a DEXA scan done. And one, we get body composition, but we also get the bone mineral density. This is a very specialized X-ray. And when you have the DEXA scan done, what people tend to do is they look in certain locations. One of the primary ones that they look at is right here, okay, right in the neck of the femur as it's going to enter the acetabulum, kind of right there at your hips, okay? And so we can scan you, and what people have done is we've scanned thousands and thousands and thousands and thousands of women. Okay? So there are established normative values for what osteoporotic bone mineral density is based upon your age, and then sort of varying degrees of either higher or lower bone mineral density in that particular area. Okay? So you go in, you get a DEXA scan. We look then, we zoom in on the neck of your femur, and we find your bone mineral density there. And so this is from a 68-year-old woman. And it's hard to tell just by looking at the picture here. It's a little bit brighter in the one on the left. And we get a value for her bone mineral density. Okay. That value for her, you guys can't see, she's in this green sort of area here. She is just ever so slightly above kind of what the average normative value is for a woman that's 68 years old. Okay. So she's fine. We then would look and say, here's a 74-year-old woman. She had a scan, and we figured out what her bone mineral density was. And you go down, and there's a statistical calculation called a standard deviation. And so a standard deviation tells us how variable a measure is when you've calculated the mean. So you get the average of everybody in class. You're all going to be a little bit different. How far each of you is from that mean, you can use that to calculate a standard deviation. And so we lay out these things where essentially if you are greater than 2 standard deviations below the mean value, that means that 95% of people that are your age have a higher, bone mineral density value. You're 2 standard deviations below, you are said to have osteoporosis. Now, there's an area, a transition area in between, just like there is with everything, right? You can be pre-hypertensive, you can be a pre-diabetic, you can also be pre-osteoporotic. We call that osteopenia. So it's begun to decline, but it has not gone down quite far enough yet to be considered truly osteoporotic. Okay? Truly osteoporotic. So this is what we do. All right, ladies, as you all age, as you get into sort of post-menopause, your doctors will very likely, if you are able to go, have a DEXA scan done on you to assess your bone mineral density. Okay? Now, what I would argue, if you guys can hang on to it long enough, what you also should do is you should all go get a DEXA scan. Go be in one of our departmental research studies now. Go get a DEXA scan now, as you all will see. Most of you are probably right at about peak bone mineral density right now. Okay? Peak bone mineral density now. So if you know what it is now, then as you age, as you get postmenopause, you have a more solid individualized reference value for you than simply just relying on the average. So that imagines that we get the scan, we give you the information, we can't diagnose you with anything, we can give you the value, and then you have to hang on to that value and travel with it for however many times you're going to move and all of this, until you're in your 50s or 60s or 70s. So it may be asking about, but okay, that's a thing that can also be done. In some instances, we see osteopenia or osteoporosis in people that are adults. It's not unheard of. It's not unheard of. So, as I said, the big problem with osteoporosis is that your bones are brittle. Okay? So, I'll give you guys an example. Saturday, Ellis is out running, sprinting after me on the sidewalk in front of our house, and she takes a really bad tumble and smacks her face on the concrete, and she's all, bitter lip and scraped up her sort of whatever that space is between your nose and your upper lip right there. She scraped all of those things up. She fell down. She skinned her knees. She's fine otherwise, right? She didn't fall over and break her hip or break her femur or anything like all of that. Okay. If I had, I don't know, we had Nikki stand up and we asked Dr. Bellers to come over and trip her and throw Nikki down on the ground, we're probably not going to break Nikki's hip. We're not going to do that. That'll be very nice. Okay. But any of you all that have grandparents, a grandmother, or a great-grandmother who is alive, there's a reasonable chance that your grandma fell over, she might break her hip. Okay? And I can tell you, my grandfather, my paternal grandfather, fell, broke his hip, and then basically never recovered. He was in a nursing home for 6 or 8 years after all of that. Okay? And we think, oh, you fall over, you break your hip, it's going to heal, all of those things, yes, but the increased rate of mortality after all of those things, those falls and those fall risks, is pretty crazy. Okay? Think about this. Lana, are you and Emma friends? Acquaintances? Yes, y'all are friends. She ever done anything to annoy you? Never? Emma, has Lana ever done something to annoy you? What? Never? Okay. Is Phoebe in y'all's little friend group? Has Phoebe done something to annoy you guys ever? No? Okay, well, if we ask her to stand up and give Emma a friendly kick on her fibula out here, you could probably kick someone in the fibula and break it, right? Fibula is really small, it's weak. Why is it there? Nobody really knows. We were at the Natural History Museum doing a different thing a couple of weeks ago. We were looking at the dinosaurs, and I'm like, why does the giant brontosaurus also have a fibula? Their bone structure is very, very similar. Anyway, I can kick you in the fibula and break it. I probably can't kick you in the tibia and break that. I can't kick you in the femur. We broke a guy's femur when I was a PhD student. He had a spinal cord injury. We were doing E-stim on him. We broke his femur. You don't ever want to be in the room when you do a contraction and you hear somebody's femur snap. It wasn't great. Luckily, we were at a hospital. He couldn't feel it. I mean, he was just like, whatever, it's fine. And so he turned out okay. It was all right. But think of people that have osteoporosis as like all of their bones are like your fibula. They're very small. They're very brittle. They're much easily breakable. All right. Okay. So any of you ever like broken a bone like in your wrist or your fingers or your hand or something? Much more so like you don't break your humerus that often. Right? Why do you guys think that is? Why do you break your wrist or maybe the radius or the ulna or something there? But you don't often like break your femur or like the bones in your ankles or those kinds of things. Okay. You're right, Lauren, they do bear more weight. So they're stronger. Right? Did you guys talk about in physiology or anatomy, talk about something called Wolff's Law? Maybe? Ramsey, Google Wolff's Law for us. Say Wolff's Law and bones. Tell us what you find. Also, what is in your Starbucks cup? What is that pink liquid?
Zip Fizz.
Zip Fizz?
It's like a little.
Ooh, okay. Okay. I like it.
Wolff's Law states that bones will adapt to the degree of mechanical loading such that an increase in loading will cause the architecture of the internal spongy bone to strengthen, followed by the strengthening of the cortical layer.
Okay. Right? Wolff's Law is the bone-related manifestation of if you don't use it, you will lose it kind of thing. Okay? How do I load my bones? Madison, stand up. Is Madison loading any of the bones in her body right now? Are there muscles that are, so muscles, no, the muscles themselves don't attach to your bones, but the tendons of the muscles attach to the bones. So when you contract the muscle, that force gets transmitted onto the bone. So is Madison contracting any muscles to be standing right now? Yes. Yes, I was. Okay. Siri, is Madison loading her bones right now? That's great. Or Alexa. Madison, do you feel like you're contracting muscles? No. Okay, but if I ask you to just totally relax, would you stay standing? Okay. So what bones is Madison loading? Daniel, what do you think? What bones is she loading right now? Okay, yes. Okay. Any? Your spine, okay. Does your head have a weight to it? Does your head weigh something, Madison? Okay. That's compressing, right, on your spine. Your upper body weighs something. You've got ground reaction force. You're loading through your hips, down your femur, mostly through your tibia onto your feet. Are you loading your fingers? Are you loading your wrist? Not as much, okay? Now, jump. Higher.
I have to jump higher.
Jump high, as high as you can.
No, that's not very hard.
Okay, well, that's okay. All right, boom. When she lands, what is she loading when she lands? Okay. Weight of her body. Let me get a little bit of acceleration from gravity. So we're applying a little bit extra than just standing. Okay. Now, so you run a lot, don't you?
Yeah.
Okay. Guess what you're doing when you're running? You're contracting, but I'm running. You can sit down. Thank you. But I'm going to run. Okay. And I'm running. We'll assume that I don't run nearly as fast as Madison. But when I get out here to heel strike with my front foot, okay, I am absorbing all of the weight of my body, and I'm absorbing all of some of that momentum that I have going forward. And then it all goes up through my foot, through my tibia, through my femur, into my hips, right? That ground reaction force that keeps me from falling flat on my face. So I absorb all of that, and then I go on and I take another step. Then I switch and it goes on to the other one. Okay. Standing, walking, running, jumping, especially landing from jumps, especially when we run, provides a lot of force applied across your hips, your femur, and your tibia, and some parts of your spine. Not nearly so much your hands, your wrists, okay, and your forearms. And so by Wolff's Law, when we load these bones in this way by doing activity, it then stimulates osteoblasts. And the osteoblasts will deposit more mineral in things, and those bones will grow and strengthen. Because they sense, ooh, we're loading them a bunch. Every time we load them, there's a risk that they could break. So let's make them stronger. Okay? So why do you break your wrist in these things? Because those bones are weaker. Because you don't ever, like, you walk around. How do you, I'm like, if I walked on my hands, did hands in all the time, then I would load those in a much better way. Okay. Only ever broken one bone in my body, that was my thumb. So, which is pretty terrible. And it really wasn't a tendon pulled off of the bone. Yes, please.
Your handstand against the wall and do a vertical push-up.
I have done those before. I can't do the hands. I'm going to have to throw my ass up there. But I have done those, okay? Very hard. But you are then now, you're loading, right, all of that stuff through, right, through your humerus, radius, ulna, those things, okay? Gymnasts, people that tumble, are going to do better. Why? Because they're doing, like you're doing round offs and those things, you're going to load that way. Also, gymnasts destroy their bodies from all of the loading that goes on. They have really good bone mineral density, but they're all going to tear up their knee, their Achilles tendon. Like, it's just, they're all time bombs, just waiting to happen because there's so much repetitive stress from all of that. Okay? Okay. So the places that we really, really care about with osteoporosis. We're really worried about the neck of the femur and here, and we're also very worried about the wrist. One of the reasons we worry about the wrist is, one, it's already more fragile than other places, but two, when you fall, and I can tell you guys, as you age and you lose your balance, you're going to fall. What do? You put your hand down to break your fall, and you put these weird loads on your wrist, and so it's at a much bigger kind of increased risk from all this. All right. So that's what we're going to be worried about. Okay. So what are our physical activity recommendations for people that have osteoporosis or potentially that are at risk of developing osteoporosis? We want to increase bone mass using high impact exercise. We've spent a lot of time in class talking about the resistance exercise is good, the aerobic exercise is good, and not making too much of a fuss about which one might be better or worse for particular things. Specifically for osteoporosis, high force activities are the best, okay? So in this way, grandma needs to go to CrossFit, okay? Grandma needs to squat, she needs to run, she needs to do box jumps and things like that. Military press, we need high force levels, which we very often get from resistance training and from running fast, okay? Riding a bike is not good for osteoporosis. Dr. Larson, they've done some studies, they have some data. She's a big cyclist. You will see professional cyclists who are like guys that are in their 30s who look like they have hip osteoporosis because they spend all their time weight supported on a bike and there's actually no load there that's being borne, okay? So you need to run, you at least need to walk, jump, squat, these kinds of things. We want to load the femur, the hips, and your vertebrae, all right? So that means grandma needs to do overhead press like this. You need to press like this, okay? She needs to carry that weight on her back when she does a squat, if possible, okay? So in this instance, high impact stuff is really good, okay? What I will also say about this, as I mentioned earlier, ladies, you guys very likely are very close to having your peak bone mineral density forever right now. You're going to spend the rest of your life like the Red Queen in Alice in Wonderland, running as fast as you can to stay in the same place. Okay? You accumulate bone mineral density now, just like when we see aging stuff next week. We accumulate muscle mass now. We accumulate VO2 max now. And we just try to hold on to it for the rest of our lives for as long as we can. Okay? Those of you that did weights or you ran or you did some kind of high impact stuff when you were in puberty during your teenage years have higher bone mineral density than folks that have done nothing up until then. Okay? You can still increase it if you take up doing those higher intensity things now, but it may be a little bit more difficult, right? But what you want to do is to accumulate it and then keep doing things so that you can hang on to it build it up before you get to menopause. Because once you hit menopause, it's going to go down. It's just a matter of how far and how fast. Okay? How far and how fast. Much in the way that guys and their testosterone levels, it's going to be the same thing related to muscle mass, much more so than men. Okay. Okay. Questions about any of that? Ladies, have any of y'all anybody had a DEXA scan and know what your bone mineral density is? Okay. Keep your eyes peeled. There will be emails. We do stuff all the time in our department and studies where we can give people DEXA scans as part of kind of a larger thing, if that is of interest to you. Okay? Okay. So now let's turn to not so much degeneration or loss of the bone mineral density. We're going to talk about damage to and degeneration of the articulation between one bone and another. So the degeneration of our joints. Okay. So what we tend to see with osteoarthritis is a breakdown of the articulating cartilage. So the cartilage, those sort of spongy pads that are going to exist in between the bones that allow articulations, especially at the knee and the hip, okay? What we're going to see is that over time, these things can progressively get worn out, get broken down, and they cease to exist. And when that happens, when you try to move, you get a bone that keeps rubbing up against an adjacent bone, okay? Which is not so great. You want to know what that feels like? I'm happy to let you guys feel sort of what happens in my shoulder as the head of my humerus hits my acromion process all the time. Okay, So what happens is, as a result, this breaks down, then you get bone-on-bone interaction. That results in inflammation, in pain, and an impaired range of motion. Okay? What separates osteoarthritis from rheumatoid arthritis? Okay? Osteoarthritis, you get degeneration, and that degeneration then leads to inflammation because there is this damage. Okay? Rheumatoid arthritis, the inflammation is the cause. You get inflammation, and the inflammation attacks the cartilage in the joint. Okay? And so you've got to be very, very clear that sometimes they may present and look in a lot of the same way. But the inflammation is a secondary thing that is due to all of the initial breakdown. It's not what causes the break. Okay. So of the things that we've talked about, okay, there's about 20 million people that have OA. So this is the one that's very, very common. Okay. It does not generally lead to swelling in the joint. So it's not an inflammatory in origin. You may get some inflammation after there is degeneration, but your joints are generally not going to swell up and look like there's a grapefruit on your knee or anything like that. Okay? So what we have found, and it was a little bit controversial, it's not so much anymore, and it doesn't always make a huge amount of sense, is that exercise, specifically resistance training, seems to be one of the best treatments for osteoarthritis. Once your cartilage has been broken down and it's gone, it's very difficult for us to get a lot of it back. Okay? It's very difficult to get it back. People that have arthritis, it really hurts to have them exercise. It hurts a lot. And yet if they can manage to push through that, then they do tend to see some better outcomes. So here we have on the left, healthy knee joint. Okay, healthy knee joint. On the right, this is what happens when the articulating cartilage becomes degenerated and mostly goes away. When you get bone interacting and rubbing over the adjacent bone, okay, you get bone hypertrophy. It's not a good kind of hypertrophy. What it is you develop bone spurs and things. So those two things are going to interact, and the bone you may actually make more bone, but it's not smooth. Okay, it's all of these little bone spurs, these little things that are going to be in there that are going to create this very, very rough surface and lots of areas to interact and kind of nick each other and cause pain. Okay, so there's no cartilage. This knee is going to hurt when we move. Okay, it may not hurt just sitting there, but when you move, when you do flexion and extension at the knee, it's going to hurt. You don't need to see it do these things. All right. So how do we treat OA? So initially, one of the most common ways we treat OA is through pain medication. We give people non-steroidal anti-inflammatory drugs like ibuprofen, so Advil, okay, aspirin, Aleve, things like that. We try to deal with it with these things. We can inject steroids into the intra-articular space. Think of if you've ever heard of someone or you've ever had a cortisone injection into a joint. Okay. I've had cortisone injections into my shoulder, and I've had them at C5 in between my vertebrae in an effort to try to calm down some nerve pain and things that's going on there. Okay. We ask people to lose weight so there's less load being borne on those bones. That can be somewhat helpful. Physical activity seems to promote the health of whatever cartilage you have left. Okay. We want to try to be active now in an effort to promote the health and the secretion of synovial fluid and things in the cartilage that we already have. If things get really bad, then we are left with our kind of best solution is a joint replacement, especially at the knee and at the hip. Okay. If you want to see something that looks pretty crazy and wild and gruesome, YouTube knee replacement surgery. Okay. Watch people hammer this joint into the head of the femur. Okay? It is crazy. Okay? But when we do joint replacement, people feel immediate relief once you kind of recover from all of the craziness of them pounding those things into the head of the femur and the tibia. But people get immediate pain relief, immediate increase in range of motion. That's good. Same thing at the hip. The problem is that these things may last 10 years or 15 years, and you're just going to have it again. My father-in-law has had one hip replaced twice. The other hip has been replaced once. And he feels great. As soon as it gets done, he feels way, way better. But over time, these things are going to also, the joint, the artificial joints themselves are going to degenerate. Okay. So now we'll talk about rheumatoid. So rheumatoid is what is referred to as autoimmune disorder. What that means is that Phoebe's immune system is going to attack her joints. Okay? You're going to make all of these antibodies that are going to attack the cartilage, the bone, and the synovial fluid in and around those joints. We don't really know or understand what causes that, why it happens, what triggers it to come on. Okay? But it does seem to have a bit of a genetic issue. It does tend to run in families. It really seems to affect hands, wrists, okay, elbows, knees, feet, and a little bit of the cervical spine. And if you have it on one side, you very often kind of have it on the other. Okay? There is no known cure for rheumatoid arthritis. The best treatments that we have are pain medications and immunosuppressant drugs. I meant to look up what it is this morning. I can't remember if it's Xeljan or there's, you see them all the time, but you ever see the commercial where it's like, this is for RA, but please notify your doctor if you plan to travel out of the country, be in contact with someone you need to get tested for TB and pneumonia and all of this host of things, because what it does is they just give you a drug that suppresses your immune system function. Okay? So it's almost like a pharmacological sort of version of giving someone HIV, right? We're going to suppress immune function. That will then stop the flare-up, stop the attacking of the joints, which will be good, but it may make you very, very susceptible to infection from a host of other things. You just have to be kind of careful and wary out of all of them. Okay. Okay. All right. So this one stuff goes on. All right. So the physical activity recommendations for arthritis in general. Okay. So a big barrier for people. You guys will talk about barriers to behavior change and things when you get into lifestyle intervention and those things, is that people tend to think that if I am more active, because it hurts when I'm active, I'm only going to exacerbate my symptoms, only going to exacerbate my OA or RA. And what we know is that that is actually not true. Okay. So if you know anyone that has these things, my mom has very bad, especially in her feet and her hands. She has very bad osteoarthritis. And what we do is we try to encourage her to be as active as she possibly can all the time. Okay? And so that can be good. Okay? So what we do know is that we see reduced fatigue, reduced inflammation, reduced pain in folks that do resistance training, walking, kind of symptom-limited types of exercise. Okay? Otherwise, our recommendations are very similar to those that are from a healthy individual. They can do a couple of days a week of resistance training, 3 to 5 days of aerobic training. Just do what you can, but don't make necessarily your pain and things flare up. Certain exercises will exacerbate joint pain. Okay? So my mom likes to go to water aerobics. She goes water aerobics because the water helps to make, add some buoyancy, and it's less stress on her already painful joints and those things. Okay? So for people that have pain from RA and OA, they're trying to find alternative exercises that may limit the stress on those joints, we may limit the range of motion on those joints or something that can potentially help promote having to be more active. Okay. So that's kind of where we are. Okay, let's stop here. We'll take a 5-minute break. So at 11:30, we'll come back. We'll talk about some low back stuff. You guys can laugh at my inability to be able to bend over and touch my toes some more. And then we'll call it good for. We'll record. Back to our share screen. Okay, so weirdly enough, of all the things we talk about in class, the one thing that most of you will likely experience in your life above everything else is low back pain. Okay? It's very strange. Okay? Very strange. So what we mean by low back pain is muscle tension or stiffness, okay, as well as what I can only characterize in some instances as the most debilitating pain that does not go away that you can ever experience. Okay. So about 80% of Americans will suffer from low back pain at some point in their life. Okay, about 80% of you. 20% of people will have it chronically, which means it will last longer than 6 months. Okay. There's a very, very good chance that these statistics tell us that every one of you will miss a day of work or something you would like to do on one day in your life because you have low back pain. Okay? So this is one of the most common things that we're going to see. It's the second most common cause of disability. If you group low back pain with osteoarthritis and the pain from that, it's these kind of two musculoskeletal things are the leading cause of disability in the US. Okay, so to reduce the probability of disability, people with low back pain need to become more active. Okay, we need to become more active. We need better ways to treat this, but being more active, increasing flexibility and range of motion, and increasing the strength of the muscles that are going to kind of work around there, as well as if you do repetitive stress things as part of your job, right? I worry about all the folks working at the Amazon warehouses and things, just load stuff all the time, right? You've got to have proper form or you're going to eventually have low back. Okay? So one of the things we look at with low back pain is we try to identify the origin. Okay? What's the origin? Do you have a specific spinal cause? Okay? There may be pain associated with spinal we call stenosis. Stenosis is narrowing. So is there a narrowing in the spinal column such that what happens is that you bump your spinal cord somewhere, or more commonly what happens is you're going to press on the nerves as they lead out of the vertebrae through the foraminal space. Either you may have a herniated disc or you may have bone spurs or something that's going to go there. Weirdly, though, about 85% of all cases do not have a specific spinal cause, which makes it really, really difficult to treat. Okay? It's really difficult to treat it if we don't know exactly what it is. We break them down into acute, subacute, and chronic. Okay, so if you have pain for less than 6 weeks, that's called acute. Subacute is 6 to 12, and then chronic is greater than 12 weeks, greater than 3 months. Okay. Usually, though, when you have pain, you're either going to have the pain sort of in your low back, in some area around the back, or you may have pain that is going to follow the line of the nerves that leave that area of the spinal and go out to someplace in the periphery. Okay, and so based upon that, we can try to diagnose where exactly in the spinal cord do we think there may be, or what vertebrae, like what's our location of an issue. Okay, so where are things getting sort of pinched on, or where might there be inflammation that's pressing on these particular nerves? Okay. You guys probably learned about, maybe in anatomy, did you guys learn about dermatomes at all? right? There's like a L1 dermatoma, or L2 dermatoma. What they're really getting at is like, what is the sort of peripheral tissue that is innervated by nerves that originate at that location in the spinal cord. Okay? So then once you've done all of that, once we find what we think is the location, people will then check and see, is there pain that is made worse by doing something at the level of the lower back or someplace in the spinal cord? Is it exacerbated by movements in the periphery? Do you have motor function? Do you have sensory function? Like, what are all of the things that may or may not be compromised because of all of this? Okay, so I know you guys have seen all of this before. I just want to point out or re-emphasize a couple of things. Okay, in many ways, to understand low back pain, it all comes back to the anatomy of the spinal column. Okay? And so if we look at all of this, this is a top-down look at a single vertebrae. Okay, and so we have the pedicels that are going to come off right on the side, our little wings. We've got the lamina coming off in the back. We've got our spinous processes from all of those. We have this cartilaginous pad, right? It's going to sit in between the kind of vertebrae that are proximal and distal to us. Then in the middle, we have the spinal cord, and then we have the nerves that are going to lead out of the sides at each level from there. Okay? A lot of the problems that are going to lead to low back pain, or really any kind of back pain or neck pain, are going to originate with something going on as it relates to what the location of this intervertebral disc, as well as the muscles and things that control our posture that may or may not allow this area where the spinal nerves are going to lead out of this vertebra. So we also need to understand how these individual vertebrae articulate with each other to know why certain kinds of movements may exacerbate our pain or may lead to and cause those things in the first place. Okay? Your spine is a weird joint. I've always felt that way. Okay? You have a little bit more range of motion in some places, but also the anatomy of it and the way that it sort of is not perfectly straight has good things, but it also puts a lot of stress on our lower back. Okay? But remember, when you flex or extend at your back, what happens is as these vertebrae sit on top of each other, they're going to want to either sort of pinch in the front, right, on the ventral side, or they're going to want to pinch on the dorsal side. Okay? As you lean side to side, they're going to shift left and right and kind of squish and pinch on either side, potentially. So making sure that this intervertebral disc stays where it needs to, making sure that you have proper form and muscle strength so you can hold the spinal cord or hold the vertebrae in the right position as you move is all going to be really, really important. Because if you don't, then you can cause inflammation, you can cause some tissue damage around these things. And as you get swelling, either the swelling will press on the nerves, or you can squish the disc, you get a herniated disc, and that can press on the nerves. Okay? So one of the most common things that happens with people with low back pain is something called a disc herniation. Okay? A disc herniation happens when you tear the outer fibrous layer, okay, of the intervertebral disc. So you have a tear. The inner sort of piece of all of this is going to be much more liquid filled, much spongier. It's a good shock absorber, but you tear it and then you load on the disc and it squishes out through the tear and it changes its shape. As it changes its shape, it wants to go to the place where there's some more space. And that very often is just going to be just outside of the foraminal space where the nerves are trying to leave the vertebrae from the spinal cord. And so it presses. You get compression there. You get compression, you get inflammation, you get swelling. And what happens then is it can activate those nerves, right? or it can inhibit those nerves. So what you get is pain, you may get numbness, you may get weakness, okay? That's going to be the L5-S1 spinal segment, or vertebral segment, is the most vulnerable to injury because of the shape of the spinal cord or of the spinal column in that area. Okay? As we transition and we get this little bit of kind of forward bend in the lumbar spine before we get into the sacral vertebrae and it bends back in the direction, what happens is when I stand up straight, I'm okay. But as I start to move, and I have my shoulders and my head over the top of all of this, there's a lot of flexion and extension at that segment, and the load is not always right, kind of in line with those vertebrae. So I can get a lot more sort of forwards or backwards movement out of that particular joint than I do like in my cervical vertebrae. The head always tends to stay, in a lot of instances, kind of very parallel or very perpendicular, and stacked right over the top of it. As I get that curvature in my low back, then I'm always kind of loading on the front half of those vertebrae. And that can potentially, over time, lead to these kind of disconnections. So we see a lot of things that are going to continue. Here are some MRI pictures of all of these things. These are from the side, so you're looking in from the side of these folks. Each one of these kind of squished squares is a vertebrae. The lighter area in between them is the intervertebral disc. So this one here on the left, you can see right here, we're pushing in. Here's the disc has been squished, and it's been pushed in onto the spinal cord. The one in the middle is even worse. You can really see how it's gotten sort of pushed right in from there. Okay. And then similarly, like you can see, this person actually has one that's bad, another one that's coming. If we look at it that way, this person in the middle is in real bad shape. They got a really bad one. This one's already happening. We even got one there. Okay. So these things tend to progressively develop over time. Oftentimes in response to changes in posture, oftentimes in response to some sort of an injury or weakness that you have someplace, you change and you do things over and over again, and eventually this is what happens. So what are we trying to do? How do we fix this? Okay. Well, what is it we do to fix this? You have done what Dr. Mike just had done, what Dr. Mike has had done like 3 times now. It's called a spinal fusion. So what they do is they go in, they suck out the disc, they put some fake stuff in there, and then they screw these vertebrae together. We're going to lock them in place so that you cannot move at that particular segment. But by doing that, then they're not going to be able to kind of get out of alignment and potentially cause pain, press on these nerves. The downside of spinal fusions is that it reduces your range of motion. Right? It reduces your range of motion. So my dad at L4, L5, he's had one kind of baby fusion done. And in the spring, he's going to have another one done where they're going to go in and actually they're going to put a rod in. It's going to run from like S2 all the way up basically to T12. And put a rod in and they're going to basically lock in all of his lumbar spine. Okay? And when you get that done, like you can't bend all the way over anymore to be able to like tie your shoes and do things. But his whole thing is a mess. I meant to get we have his MRI pictures. They're wild. It's wild to see all the things he's done. We actually went from Northwest Arkansas. I came over here to Oklahoma City to see his spine, a surgical specialist, and I got to go with them and see all the pictures and those kinds of things. He's in real bad shape. His looks like an S down there. So I'll show you guys some stuff. Okay. So that's the thing. It can be useful, but you lose range of motion. Have enough of those things done, you lose enough range of motion, and it becomes difficult to do some kinds of your activities. Okay. So it can be a pretty rough deal. Okay. Other things that may lead to low back pain, right? So there are these abnormal spinal curvatures. Okay, ladies, I imagine most of you remember probably in elementary school or early in junior high having to go and have a scoliosis test done. We're looking for lateral curvatures in the spine. Okay, they're going to go side to side. You may have kyphosis, which is going to be this abnormal or extra curvature kind of up behind your shoulders, or lordosis, which is an extra bend in the low back. Any of these things, because there's an abnormal level of curvature, where that abnormal curve is, there's going to be extra stress placed on the vertebrae when you load in those particular areas. So, like my dad, for instance, he has scoliosis, so it looks like this, except his gets to about here, and it bends one way, then it bends back in the other way, and then it bends back. So it's like an S in his back. Right? Very, very bad. He has one leg that's way shorter than the other. They sort of compensated by like being all mush over walking style. Okay? Years and years and years of having scoliosis and then running marathons all the time, you just pound all of this in. And in an effort to maintain your posture, you start moving. And so then it kind of spins off in the other direction. And that's fine. What happens is over time, then you get lots and lots of pressure. And you get lots of okay? So when we check for scoliosis, you can do Adams test for the lateral curvature. If you've ever had the scoliosis test done, this is what they're looking for. Here is a person that has had a rod put in, right? Here, these people have gone like even not even just to T12, but like way up, like maybe T5 or T6 or someplace here. But you can see how it curves. You can see these kinds of things. My dad's looks like this. Okay? So many people have these kind of weird, crazy things. I don't know. So my wife's aunt had this surgery done, what my dad had done, basically the exact same thing. And she got 3 inches taller from pre to post surgery because she was all like, down. So she was as tall as my wife, and now she's like 3 inches taller. My wife's not happy about that. But she feels a lot better because she had all of this done. I don't know how you function. I don't know. You just suck it up and deal, I guess. Okay? So it can be really, really bad. So people that have abnormal curvatures, oftentimes it may develop from muscular imbalance. Some may be due to malformed bones. You just want to try to do some exercise for all of these things. You want to do things like yoga or Pilates or some kind of stretching to make sure you've got a good range of motion. And you want to go to physical therapy or someplace and they can check and see if there are any kind of muscular imbalances that maybe lead to you kind of compensating in the direction for. Okay. And that is that. Right? So we're in a place where we've got 2 sets of PowerPoints left. Okay, 2 sets left. We have 4 class days left. So my plan, 4 class days. Monday, Wednesday of the 2 weeks after Thanksgiving, and then we have our final week after that. Okay. So obviously my plan is that the last Wednesday before finals, we will do a review session. Okay. That leaves 3 class days for 2 lectures. So we get a day off Sunday. You guys would like a day off from that. I don't care which of those days it is. Okay. Would you guys like the Monday when we get back from Thanksgiving back? Would you like the Wednesday of that week off? Would you like the Monday of that other week? Of those 3 days, which day would you guys prefer to not have class? Doesn't matter to me. Just assume that Wednesday of that week before finals, we'll do a review. But you can have one of the other days off. Anybody have any thoughts? The Monday before the review session? Yeah? Okay. Okay. Phoebe wants Wednesday of the week we get back. Okay. Anybody else? My folks on Zoom, do y'all care? Anybody have a preference? Anybody even there? Oh, somebody put something in the chat. Dan doesn't care. Yes, Cameron, Monday is dead week, even though we're not supposed to call it dead week anymore. It's not dead, you still have class. In the olden days, when you had dead week, there was literally the week before finals, and you didn't have class, you didn't have anything.
Yeah.
So by us calling it dead week, you guys think that, well, I shouldn't do anything. I'm like, no, it's just a regular class. It's just a week before finals.
I think we have 1 week back.
Yes. Yeah, that's right.
Monday up.
Oh, Monday after break. Monday, it was unclear which Monday that was. Okay, so here's what we will do. We can just take a vote, I guess. Do you feel comfortable taking a vote? All right, so my people that are on Zoom, this is your chance to get a vote. We're just going to count these things up. So we've got Monday after Thanksgiving. We've got Wednesday. Let's call that Wednesday after Thanksgiving. Then we've got Monday of dead week.
Would that be the 6th? Just the 6th? If our final on the.
Yes, no. Our final is on Wednesday.
50. Yeah, so it would be Monday, November 29th, Wednesday, December 1st, or Monday, December 6th. Okay. All right, so my folks in class. Monday after, right after break, so next Monday. All right, I got one from Nikki, okay?
Actually, I'll do the Monday after.
Okay, Ramsey wants that one too. We'll add these other ones up. Okay. The Wednesday of that. Okay. I got one for Phoebe. Okay. And then the Monday of dead week. Is that everybody else? 1, 2, 3, 4, 5, 6, 7. Now we'll go through and we'll try to add up these others. Okay, Dan doesn't care. So I've got, well, when you go write this on the board, so I can just read these off. All right, so we've got one for Monday after break. I assume by Devin putting the little hat thing, that also means yes, the same thing. It's 2 votes, another one for Monday after break. I don't know what Kathy's I'm good with it means. I don't know what that means. Cameron says Monday after break. Devin trying to vote twice, that's okay. Kaylee is a Monday after break. Gianna, Monday after break. Dan is a Monday the 6th, so that's Monday of dead week. Okay. Jordan is another vote for the 1st, so the Wednesday one. Kathy votes for the Wednesday. Cameron says Monday after break. Vale says Monday after break. Madison says Monday after break. Mallory says
Monday after break. That's hard.
okay, so I guess it is Monday after break. We will not have class. Democracy at work. Okay. There we go. All right, so I guess I will see you guys on Wednesday of next week. You guys have a lovely break. If you're traveling, be careful. Okay.